Okay, I officially have 1:02 Eastern. And so I'm Jessica Schuster. I am active as an ACRO member and previously participating in the new practitioner group. And we are really enthusiastic today to be joined in a joint webinar from ACRO and the QuadShot News. And we have the full team with us. We have Dr. Laura Dover, a radiation oncologist that's currently practicing Ascension Health at St. Vinny's East Cancer Treatment Center, excuse me, outside of Birmingham, Alabama. Certainly looking at how best to serve that particular rural community. And one way is keeping yourself up to date is such a challenge after you leave residency. And I think the QuadShot News has really filled that one of those niches. And then we have Dr. Caleb Dulaney, and he's the co-founder and co-writer of the QuadShot News. And he's currently at the Anderson Regional Cancer Center in Meridian, Mississippi, completed his residency at the University of Alabama, and is looking forward to kind of educating us about the recent highlights from ASTRO. And then we have Dr. Sam Marcrom, who's a radiation oncologist at the University of Birmingham, where he additionally completed his residency. And we're looking forward to kind of hearing some recent updates. So thank you guys so much. And I'll turn it over just for some housekeeping. I will monitor the chat for folks, but while you're listening in, if you'll keep your microphones, turned off, and then I will kind of provide the questions to our speaker at the end when we have time for kind of a Q&A period. Thank you so much.
All right, thank you again. My name is Caleb Dulaney, so I'm one of the QuadShot members, and so I'm going to share my screen here, and we're going to try to review some of the highlights of ASTRO 2022. I also may have slipped in a few highlights from ASCO 2022 as well. So we'll go ahead and jump into it. Again, we're going to try to be fairly brief to leave room for questions at the end and discussion. So I practice in community practice, so I see all types of cancer, and that's kind of my focus in reviewing all these highlights is how does this impact my daily practice? All right, so again, I slipped in a few highlights from ASCO 2022, in addition to ASTRO, that I thought were pertinent. First was the results of NRG DR002, which was presented at ASCO this year, and that was a trial that looked at metastasis-directed therapy, so surgery or radiation for oligometastatic breast cancer. And it was a phase 2/phase 3 design. So the first part was a phase 2 study to just see if there was going to be sufficient difference to move into phase 3. So the phase 2 part included 125 patients. The definition of oligometastatic disease was 4 or fewer Mets, a controlled primary, and no evidence of progression on standard systemic therapy. Most of the patients, the vast majority, were hormone receptor positive and HER2 negative. Most of them also, interestingly, only had a single Met. So 60% only had one metastasis. 80% had metachronous metastatic disease. And then almost all patients were treated with SBRT as their form of metastasis-directed therapy. So they were randomized to either continue on their standard chemo with or without metastasis-directed therapy. So the study found that SBRT or metastasis-directed therapy did not improve progression-free survival. And at 36 months, there was no significant difference in the rate of progression-free survival. So that's a lot different from a lot of the other oligometastatic trials that we've seen and a lot of the excitement around oligometastatic disease. So one of those reasons, the local progression was much lower with metastasis-directed therapy, but the majority of patients progressed somewhere else. So they progressed outside of that area. which probably led to that there not being a big difference in progression-free survival. So this study, is a little bit of a disappointment because of the excitement around treating oligometastatic disease in general. Some of the questions I came away with were, are there certain subsets or more specific clinical scenarios? They included breast cancer in general, but we all know that there's a very broad spectrum of disease with breast cancer. Are there specific scenarios where we might still have a benefit from metastasis-directed therapy? And then another question I had too was, and this is kind of, with the major change in managing prostate cancer with targeted or molecular imaging, do we just not have a good picture or a good way of identifying people with truly oligometastatic breast cancer? Is our standard imaging, is it just inadequate for that purpose? So my conclusion, takeaway from this was, maybe we need to dampen some of the enthusiasm when it comes at least to breast cancer for oligometastatic therapy. I still feel hopeful that there is a place for it in the future. I think we need better data though to know who's the right candidate for that type of treatment. But at least this trial did not continue on into a randomized phase 3 trial because there was just no major difference in progression-free survival. So moving on to another study from ASCO 2022. And this
Caleb,
yes.
is this a discussion?
Okay, go for it.
No, I'm just saying, can we add some thoughts? As
go for it. Yeah, sorry.
Make it
Feel free to
less formal. Okay, thank you. I think it's interesting to think about this study, particularly in light of the CURB trial as well, which was presented at ASTRO the past 2 years from Jillian Tsai, and that was talking or looking at oligoprogressive disease in both non-small cell lung cancer as well as breast cancer, but this large population that had metachronous disease, and what's the difference in the biologic state of a metachronous net versus truly having oligoprogressive disease. And I think that's an interesting area to kind of ponder. But similarly, then that study not finding a difference in breast cancer, and I do wonder if maybe it's biology driven here, where there was a difference in that trial in lung cancer, and just kind of interesting to see the differences across histologic subtypes.
Yeah, it makes me think of the CURB trial, with lung cancer, with the imaging, maybe what we see is what there is, versus with breast cancer, it seems like we're not seeing the whole picture of, and there's other occult metastatic disease that's just not showing. And so we're not treating all of it. I feel like metastasis directed therapy is effective, almost independent of what type of histology you have. The key question is, are you actually targeting all of the disease? Otherwise, it's not that beneficial.
Yeah, and I was just going to add, if there was any metastatic disease that we could be pretty confident we're not treating everything, it would be hormone receptor positive breast cancer. Because look how many women come back literally 20 or 25 years after breast conservation with new metastatic disease. So they have these, metastatic clones circulating for literally years. So, that's probably going on in the background of almost any hormone receptor positive breast cancer that you see that's metastatic.
All right, so moving on to the next study, this was also from ASCO. So this was a randomized trial actually from China. So for nasopharyngeal cancer. So, it may be relevant to some people practicing in the United States. I think there are some caveats in Western countries to look at here, but it's still a pretty interesting study. It looked at, is failure-free survival non-inferior with radiation alone compared to chemoradiation for a low-risk subset of nasopharyngeal carcinoma. And so this was there's some older studies looking at this that kind of established, hey, we should do chemo for these patients. But there's some more recent data suggesting there might be a lower risk subset that may not gain a lot of benefit, mainly just toxicity from chemo. So it was a randomized trial of 341 patients. They had T2 N0 to N1 or T3 N0 disease, and they had to meet this low risk criteria, which is had to have small lymph node metastases if they were present. They couldn't have any mets to the low neck. no extranodal extension, and they also importantly had to have a low EBV titer. So this was done in an endemic area where most patients have EBV mediated nasopharyngeal carcinoma. So they were randomized to radiation with or without cisplatin every 3 weeks for 3 cycles. And they found that there was no difference in failure-free survival at 3 years with radiation alone versus chemoradiation. There was also no significant difference in local regional failure or distant metastasis. And there was a significant drop in acute toxicity, as you would expect, by omitting chemo. So of course, questions with this are how well does this translate to Western or non-endemic populations, particularly if it's, I think there'd be a lot of caution if you're treating an EBV negative patient, perhaps with EBV positive, this could be applied to patients in Western countries. But kind of in conclusion, if in the right scenario, patients with low risk nasopharyngeal carcinoma may be candidates to be treated with radiation alone as opposed to chemoradiation. Any thoughts or comments? All right. So moving on again. Now we're moving to ASTRO 2022. So I was going to highlight NRG HN004 that was presented at ASTRO. So the question there was, for patients, not everybody can get cisplatin with head and neck radiation. We saw in recent years with the de-escalation trials that cisplatin is pretty critical to achieving a good outcome, even for people with favorable head and neck cancer. So it's kind of the go-to, but some people may not be eligible for cisplatin. So the question is, what's the best alternative concurrent therapy? Cetuximab has definitely been around for a long time as an alternative. HN004 asked whether durvalumab, so immunotherapy, concurrent with radiation, resulted in similar outcomes to cetuximab. And so this was a randomized phase 2 study, 186 patients who had an indication for chemoradiation, but were not cisplatin candidates. And so they got standard radiation with either cetuximab or durvalumab. The trial actually closed a little early because I guess you could say somewhat surprisingly, progression-free survival was worse with durvalumab than with cetuximab. And that was because of a much higher rate of local regional failure with durvalumab compared to cetuximab. Post hoc analysis of the study suggested that some of the worst outcomes may have been driven by P16 negative disease. Let's see. So of course, questions for me were, this is, I think, an important study because we're always looking for, what's the best treatment in someone who maybe isn't a cisplatin candidate. So this helps at least say that cetuximab would be superior to durvalumab in this setting. Still, I think, there's questions of, would other types of chemotherapy like carboplatin or some other agents that maybe a cisplatin ineligible patient could receive, how do those fare against cetuximab? That's still a little bit uncertain, but at least we know that durvalumab doesn't seem to be a good agent, an alternative to cetuximab for these patients.
I'd just quickly add that we've highlighted in QuadShot recently, there's been a lot of interesting basic science work into why immunotherapy hasn't really taken off for squamous cell carcinoma of the head and neck like you would think it was, because it usually has a lot of immunologic markers that it should theoretically respond well to immunotherapy, and it has in certain settings, especially metastatic disease. But the thought or theory is perhaps when we're doing it concurrent with these huge radiation fields that are intentionally treating large volume lymph node basins, that we're actually working against the potential efficacy of immune checkpoint inhibitors by diminishing, so much of the, lymphoid tissue that has our immune cells that we would otherwise be hoping to harness with immunotherapy. So that's kind of an interesting thought, specifically when thinking about immunotherapy with, big bilateral head and neck radiation fields.
All right, the next study, Luster. This was another trial presented at ASTRO this year. So this was a randomized trial asking whether does comparing basically SBRT to a hypofractionated dose escalated radiation for stage 1 non-small cell lung cancer. So it's a randomized phase 3 trial and included 233 patients, which was actually a little less than the planned number of patients. And they just had slow enrollment to the trial. They had stage 1, medically inoperable non-small cell lung cancer. 73% of patients had peripheral tumors, and the study was designed to detect an improvement in local control from about 75% up to 87.5%. So SBRT was either 48 gray and 4 fractions for peripheral tumors or 60 gray and 8 fractions for central tumors. And hypofractionated radiation was 60 gray and 15 fractions. So at 3 years, there was no significant difference in local control. So I guess you could, depending on the perspective of this, that was a little surprising to see no significant difference. The study was a little bit underpowered. And as we can see, I would say not that the SBRT arm performed less well than expected, but maybe the hypofractionated radiation performed a little better than expected. So the actual local control for that was several percentage points higher than expected, and could have been a reason why there was no statistically significant difference. But at least numerically, we can see, the control with SBRT was numerically higher. There was also no difference in disease-free survival or overall survival. And another take on this study is, did SBRT, with it being higher dose, shorter fractions, was there more toxicity? But that was not the case. There was only 1 grade 3 event in each arm. So basically SBRT ended up being just as safe as a more hypofractionated regimen. So we could look at it on the one hand, local control with 60 gray and 15 fractions was maybe better than expected. It also, although this is not a direct comparison, there's been another trial that compared conventionally fractionated radiation with SBRT and did show a significant improvement. And in that trial, which was called the Chisel trial, local control with conventional fractionation was only 69%. So as you could expect with an increasing BED, there's kind of an incremental increase in local control. On the other hand, there didn't seem to be a lot of benefit in terms of toxicity, at least on this trial with hypofractionation. So my takeaway was that, SBRT, I don't think this trial questions the role of SBRT for early stage lung cancer. But let's say, you had some scenario where maybe you weren't comfortable or you didn't feel that 4 or 5 fraction SBRT was the right option, then 60 gray and 15 fractions may be a very effective alternative that we can see has very good chances of local control and appears to have very low toxicity. So that was my big takeaway from that, was that the 60 gray and 15 fractions is a good alternative treatment to have in your back pocket for certain scenarios. All right, so we'll move to, this is my last one, but last is another interesting trial that was at ASTRO, looking at the use of bolus in post-mastectomy radiation. So their question was, do we really need to use bolus to reduce local recurrence when delivering chest wall radiation? I think this is a long-standing question in radiation oncology. This actually was a pretty small trial, to be honest. So only 58 patients. They had a mix of what they considered standard risk, which were the majority of the patients that had no skin involvement, or high-risk patients, which did have skin involvement. And that risk was their risk of chest wall recurrence. So depending on your risk group, in the standard risk, they were randomized to either no bolus or 5 millimeters of bolus every other day. In the high-risk group, they got the less intensive bolus was 5 millimeters every other day or daily bolus. So looking at toxicity, of course, that was the initial outcome. There was no difference in skin toxicity for standard risk, but there was a significantly higher rate of acute skin toxicity with the daily bolus as opposed to every other day in the high-risk group. So as we can see here, 100% of patients and 70% had grade 2 or grade 3 skin toxicity with everyday bolus. So that's a pretty significant, 70%, that's over 2/3 of patients had grade 3 toxicity with everyday bolus. So as we can see, it really increased toxicity compared to every other day bolus. The big question though was, is there a difference in local control? Here's the local control rates between the two risk groups. And there was no difference between those with more intensive versus less intensive bolus. The authors also noted that the chest wall recurrences that did happen were mainly in the high risk group and occurred at typically at the margins of the tangent fields rather than infield. And those also happened in patients who were treated with older 2D techniques. So my question from this is I think this is a thought-provoking study, and it promotes discussion. The chances of local recurrence after mastectomy are very low. It would take a massive study looking at bolus versus no bolus to put this question to rest. So I don't really think a 58 patient trial can tell us definitively if there are small differences in local recurrence between bolus and no bolus. But there's other data and other discussions surrounding this topic. There's a very large series from Vancouver that suggests, almost independently of bolus, that the risk of chest wall recurrence is exceedingly low, on the order of less than 5%, maybe even lower than that. There's also recent ASTRO consensus recommendations that kind of question the need for routine bolus use. So I think this trial kind of contributes to that discussion of, do we need to routinely use bolus? There's definitely still a place for bolus, particularly in people who had some kind of skin involvement or who are at risk of skin recurrence. But do we need to use bolus in everyone on a routine basis? It seems like in a lot of people, it may just cause additional toxicity with very little benefit and control. So I think that's actually affected me somewhat in practice. I feel like I've have gone more towards a risk adapted approach to bolus use in the post mastectomy setting.
I'll just add a couple of things. One being, with systemic therapy becoming more and more effective, I think we need to remember for breast cancer, particularly HER2 positive breast cancer, or a triple negative that had a past CR that we're still treating while waiting on B51, that absolute risk reduction we're giving in general is quite low. So then if you then beyond that think, what additional risk benefit in absolute terms am I adding with a daily chest wall bolus? It may be very, very diminishingly small, where there's just no question it's going to add a lot of toxicity. So I think about that a lot. It's almost never do I do a bolus, And then the second comment I was going to make is, I don't know how many people that are listening use IMRT now for, left-sided regional nodal, but that's, a completely different scenario when we talk about bolus. We'll use it oftentimes a small amount just for the, higher energy beams to bring the dose closer to the skin, but we're still cropping, PTV margins at least 4 millimeters from the body surface. So that's really, most contouring guidelines agree that we're not actually trying to intentionally treat to the surface in a routine scenario.
And I think just to kind of add to that, as we continue to explore more hypofractionated regimens, even for chest wall and regional nodal radiation in multiple trials, maybe even highlights the toxicity risk even further there with keeping bolus on. So just something to keep in mind. Okay, I think this one's mine. So this was one of the plenary session talks from ASTRO, Dr. Jonathan Ford. And the question here was, does artificial intelligence using digital histopathology provide better prognostication than NCC and risk categories for men with prostate cancer? And so basically MMAI is an acronym standing for multimodal artificial intelligence. And essentially what this was is that the RTOG had a lot of foresight in 5 large phase 3 RTOG trials that looked at various questions, including length of ADT, whether to use ADT or not, actually archived pathology slides digitally. And what this group did was access those and use deep learning to try to find patterns that maybe are better than what a human could find rationally. And so they created this risk stratification based on using deep learning, and also incorporated some clinical data in with the digitized prostate biopsy slides. And they categorized a couple of different things. In this study in particular, they were looking at distant metastasis risk. And one of the primary goals was to see if this could impact whether or not androgen deprivation therapy could be used or should be used, and what benefit do you actually derive from using that therapy in addition to radiation. And the thing that's interesting about this is it was truly a prognostication tool. And so independent of the treatment that was given, this was supposed to be prognostic to help you counsel patients and make decisions. And so what they found were a couple of interesting things. One, there was greater separation in the risk groups using the MMA model risk groups, which they called favorable, moderate, and unfavorable. And they better classified 10-year distant metastasis risk than your sort of classic NCCN risk groups. But one of the things that I found one of the most interesting when talking with him and ASTRO was that 83% of NCCN intermediate risk patients in this group and 13% of high risk patients were MMAI favorable, with less than 5% risk of distant metastases at 10 years. And so, what that translates to is that this group of patients that we classically would offer androgen deprivation therapy to, they may have a very low baseline risk, and they probably don't derive that much clinical benefit from the addition of androgen deprivation therapy, which I think we can all agree is one of the worst parts of prostate cancer treatment when you're talking about non-operative treatment anyway. And so, I thought that was interesting that it's something like you have to treat 7.5 men or something like that to have one that would benefit in intermediate risk patients. And so, the conclusion from this was that the MMAI deep learning model provides a more accurate prognostic assessment of distant metastasis risk than the current NCCN risk groups. And this is something that, you have to see in light of all the other tools that exist, including Decipher and, Polaris and various other prognostic tools. But, I think that things like this are interesting and potentially really important for impacting clinical practice in terms of, am I going to administer this therapy? How am I going to counsel my patients on, what benefit they could be expected to receive? And so, I think those are kind of my general thoughts. I didn't know if Laura, if you had any others, or Caleb.
No, I just saw a question in the chat about how does this interplay with, some of the genomic risk stratifications. And, we actually asked Dr. Toward that. And basically it's just a separate, tool that you can use that hopefully would be much more accessible, quicker, once you have the artificial intelligence there to read the prostate slides, it's kind of a just automatic thing you could add to any of your assessments versus sending out a test or something like that. He even mentioned, kind of global use of it around the world as really easily implementable. So it doesn't really incorporate genomic risk, but it's potentially a much easier and cheaper tool, was my takeaway from what he explained.
Yeah, so the company, it's a proprietary software with a company called Artera. And so I don't believe it's commercially available currently, which was another question we asked. And so I don't know that you can necessarily use this, but it's actually incorporating clinical data from the patient, including some of the traditional things that we would use, is my understanding, such as PSA and age and, Gleason score and these types of things. And then also taking the digital picture and using deep learning on on the image. And apparently the image is the driver of the majority of the calculation, but the other factors are included. And so it's, somewhat uncertain as to, which one's better, or, which one you should consider utilizing. But I think it does sort of strike home this point of, this is an evolving area across a lot of cancer types, and I think will continue to be an evolving area in terms of using more than just the classic clinical information to counsel patients. Okay, and so another study we wanted to highlight is the FLASH-01 study. And so this was a study that was presented in the clinical trial session by Dr. Doherty, and was also published in October in JAMA Oncology. And, one of the questions is FLASH radiation safe and feasible in humans? And so FLASH, what is FLASH? Many of you on this call may be very familiar with what it is, but basically it is using extremely high dose rates of radiation to treat patients and or animals. A lot of the data has been done in animal models, and the dose rates that are required are very high. And so I think greater than 40 gray a second is sometimes used as a cutoff. So these are extremely quick treatments, and the idea is that in some pre-human and animal models and some preclinical data, it appears that there is preferential toxicity reduction in terms of preferential sparing of normal tissues as compared to tumor when the dose can be administered extremely quickly. And there's lots of theories as to why that might happen, but no one seems to really know. And this study, I think, is very interesting because it's prospective and it's in humans. And the first in human study that was done prospectively with protons. And so there was 10 patients. They had 1 to 3 painful bone metastases. There were 12 sites total. They used a standard palliative dosing regimen of 8 gray and 1 fraction. And they did use a proton beam for this. And it's interesting because they use something called single transmission proton beam treatment. And I'll show a picture on the next slide of this in a second. But basically, they treated the patient through and through with the Bragg peak exiting outside of the body and landing somewhere outside of the patient. And so it was sort of the plateau region of the proton beam that actually administered the dose. And one of the things that I think they were hoping to find is that this didn't have unexpected outcomes, at least in a negative way, and I would say that it didn't. In terms of efficacy and side effects, about a third had a temporary pain flare. About 2/3 had pain relief, and 50% of the sites were reported to have a complete pain response. I believe they used the brief pain inventory for questionnaire for following these patients, and very minimal toxicity, all grade 1 to 2. The most common was skin hyperpigmentation, but it was very light. So the conclusion from this is that FAST-1 demonstrates that through and through proton flash radiation to extremity bone mets is technically feasible without unexpected adverse events in humans. And I'm seeing in the chat a couple of questions about this, and specifically about why they use the plateau portion. And so it's kind of interesting because if you think about proton therapy as a tool in general, we oftentimes want to harness the Bragg peak as a way of decreasing exit dose so as to decrease toxicity. So have a quote unquote more conformal treatment to decrease toxicity. This is utilization of a intentionally less conformal treatment but doing it very rapidly and hoping that the increase in speed will mitigate that dose. And, the reason that they did this is because, there is some belief that there may be enhanced RBE in the brag peak, particularly at the distal edge of the brag peak. And the authors did not want the potential uncertainties of what the RBE was in the tumor or in the patient to be a potential confounder in terms of outcomes. And so this is kind of a picture of what that treatment looked like. And you can see that the tumor was very proximal in terms of depth, with the brag peak being much farther. They used these very standard rectangular fields. And they had a library of, I think, about 7 different types, field sizes that they just would select one based on tumor size and administer the treatment. And so very interesting, I think very exciting to think about what the potential of this could be, but definitely a lot of uncertainties moving forward.
Yeah, Sam, I had a question. Why protons? I guess we haven't seen a lot of development of flash yet in like electrons, for instance. Could you do this with a high energy electron beam or even photons?
It's a good question. So there's actually a report. The first human ever treated was reported as a European experience, and it was a patient that was heavily pretreated for cutaneous lymphoma. And they gave 15x1 using electrons with flash. And this was done, I think, in 21 and reported. But, the limitation of electrons is, penetration depth. And so because of, the reality of the electron, the depth is a challenge. And so I think protons are utilized just because they're able to penetrate deeper. As a non-flash expert, this is my understanding.
Okay, so this is me. I'm going to talk about a couple of trials that I think are really great because they really kind of create a new niche for radiation, or at least a new space or more evidence for using radiation in a particular space, which I think is really exciting and always great to learn about. So RTOG 1112 1112, I don't know how what the phrase is. It was designed actually about a decade ago, specifically looking at doing an actual prospective randomized trial for very advanced hepatocellular carcinoma, which there's very, very, very few high-level data available in this space. So as you all know who practice in the community, we basically get these patients if they're at the end of their rope and no other physician can really do anything with them. So this enrolled in particular 177 patients that were not candidates for any type of resection, definitely not transplant, not even TACE or ablation. So these people were passed over by surgery and IR. They were all receiving the standard at the time, which was sorafenib. But the real question that's remaining here, even though, they're not surgical or our candidates, the question is, are we really adding anything by treating this large volume disease with radiation, in addition to what's the cheapest systemic therapy alone? Oftentimes you're really looking at their images and questioning, at least I always would, am I really going to benefit this patient? So that's what this trial set out to ask. So these patients really, as you can imagine, have very, very high volume disease. They were allowed to have as many as 5 separate tumors, and it could span as much as 20 centimeters. 3/4 had vascular invasion, which makes sense because those type of tumors in particular really aren't going to do well with ablation because of the heat sink effect, and these large tumors don't do well with TACE because of all of the collateral vascularization that they have. So these patients that are the ones that you're probably going to be referred to begin with, randomized 1-to-1 to the plus minus the addition of radiation. The ideal prescription was 50 gray over 5 fractions, but as you can imagine, if you're dealing with disease as large as 20 centimeters and in the liver, it's moving, it's by the bowel, you know, the dose could be diminished down to as low as 27.5, which I guess is arguably on the border of whether you would consider that SBRT or not, but you know, using SBRT planning techniques. And then very importantly, which I'll go into a little bit more on the next slide, is that above all, you know, OARs were respected. So, you know, you weren't going to treat them if you couldn't achieve, you know, well-defined dose constraints for nearby healthy tissue. So the big headliner is the primary endpoint, which actually was overall survival, which was, you know, kind of a bold endpoint for these patients. It was significantly prolonged with the addition of SBRT. So, you know, relatively speaking, it did really move the needle for these patients. And that's even with, you know, almost a quarter of patients that were in the sorafenib alone arm getting salvage SBRT. So really getting these patients, you know, treated with radiation on the earlier side really does seem to make a difference, you know, especially when you're doing it in a safe way. And then really kind of to show the difference it makes when you're really respecting those OARs, there really wasn't any appreciable increase in toxicity with the addition of radiation. So, you know, one point to make is, you know, again, this was designed about a decade ago, and there has been really high level data that's kind of changed the systemic therapy, which seems to always be the case. By the time we report outcomes with radiation, there's a new systemic therapy that's in vogue. But so immunotherapy with Avastin is typically used now for these very advanced unresectable HCCs. But, you know, I think that it's fair to extrapolate, especially when doing this is very low burden to the patient and very, very safe. So the bottom line here is that adding SBRT to these very advanced HCCs that don't have any other local treatment options does actually seem to move the needle on survival. So on the next slide, I just have a screenshot of, these are the OARs that they looked at. You know, I think probably one of the hardest to achieve was, you know, making sure you're sparing adequate liver when you're talking about such high volume liver disease. But it's good to know that, you know, dose reductions are okay. More than anything, we really don't want to be causing harm with this type of treatment. And, you know, that kind of makes me think of the paradigm with oligomets, same thing. You know, there are times when we really, really kind of go up to the edge of what's potentially safe when we're talking about someone's one and only shot at curative treatment. You know, I think of GYN cancers and that sort of thing. This is not that. This is, we want to add whatever we can, however much we can, in a safe way. So just like with oligomets, no matter what, you need to respect OARs. And this is, you know, available. You can Google the protocol. Okay, and then lastly, we're going to talk about the prospective trial looking at treating what we can call polymetastatic patients. So this is really exciting because in a turn from basically everything that we've been looking at over the last few years in the metastatic realm, this was specifically looking at what can radiation add when treating asymptomatic high-risk bone mets in the setting of several mets. Like, this is decidedly not oligomets. We're only looking at patients that have numerous mets. Do we add anything by treating asymptomatic bone mets that are deemed high risk? So every patient had more than 5 metastatic sites, and all, if you were randomizing a 1-to-1 plus or minus the addition of kind of what they considered prophylactic radiation, if you're randomized to the radiation arm, all sites of high risk mets were treated. But definitely you're leaving, you know, metastatic disease untreated by your radiation beams for sure. So of course, the obvious question is, what is high risk? I'm sure, you know, sat down with their orthopedic and neurosurgery colleagues, and it's a little bit of a value judgment, of course. but this is how they defined it. So any bulky disease, so anywhere there's osseous disease that's over 2 centimeters, involvement of any junctional spine, the mobile spine, C-spine, lower thoracic spine. If there is hip sacroiliac joint involvement, or if in a long bone, femur, humerus, more than 2/3 cortical thickness is involved. So I think we need to pause right here and understand this is really a lot of bone mets. I would wager, if almost anyone you come across that has over 5 mets and has bony disease, a very high likelihood of meeting this criteria, at least at one site. And so the primary endpoint, not as bold as the last one, but very logical. The primary endpoint was any skeletal related event, which was defined as bone fracture, cord compression, or requiring treatment upon the emergence of symptoms. And when you think about it that way, it makes perfect sense how they defined high risk lesions. So that primary endpoint was almost eliminated. So it went from 29% to less than 2% at 12 months. But the real headliner here, Caleb's keeping us on the edge of our seat, is that, when looking at secondary endpoints, there are fewer hospitalizations, which makes perfect sense when looking at less skeletal related fraction. There was significantly less pain that the patient experienced over the following 12 months, but also, overall survival, when you're looking at the rate of death, it was cut in half, which is just very eyebrow raising. So I was actually at Sloan when we were doing this trial. I enrolled a lot of patients on this trial, and none of us really were expecting that, to be honest. So, I mean, of course, you got to keep that in the back of your mind. This wasn't something that was truly a big aim of the study, which should always give you a little bit of pause, but it does actually make a lot of sense when you think back to, I was thinking about medical school when we learned about hip fracture in the elderly. I mean, it had a very, very, poor prognosis when you're looking at overall survival for elderly patients after a hip fracture, and that's outside the setting of cancer. So I think when, we talk about these things happening and reducing someone's mobility, it really can make a huge impact on the trajectory of the following year. Definitely quality of life, but maybe even longevity of life. I think it's very interesting. And the other thing to keep in mind is it's extremely low burden for patients to receive these treatments. I mean, most of them, we're really talking about 0 side effects. Almost everyone I enrolled, I gave ACRO ×1, to multiple sites. And maybe they did it over the course of, 1 or 2 days, depending on how many sites they had. And I think this is really exciting. We go to the next slide. What I wanted to end on, with this trial in particular, but really more globally speaking, we always have to ask, how do we increase the amount of patients that we see? I mean, we are so far down the referral line. Even when I was at Sloan and this was an open trial, all of these patients I was only treating because they were referred to me for another reason. I was never referred a patient to enroll on this trial. But I do think oftentimes you're going to be faced with, someone sent for a painful hip met, but then they have a contralateral hip met, or they have a, humeral met that's not symptomatic at this time. Does adding treatment to those sites help? But then also, tumor boards trying to, educate the, medical oncologists. Well, yeah, that's what the next slide. That's really what I was going to talk about with the next slide.
I had a question, Laura.
Yeah.
What was the dose that they typically?
It was anything really. You could do SBRT if you wanted. Some people did that. So some people did 30 gray and 3 fractions of bone met, or they did spine SRS. Which I guess is a little. I don't know how often you could get that approved. But me personally, who enrolled in this trial, I think I always did ACRO ×1 because they were asymptomatic, and I just wanted it to be really low burden for them. I'm not sure the amount of people that got high dose versus conventional.
That's why I know there's been a lot of excitement and discussion about the trial. I think a lot of people are waiting for the manuscript to come out because there's there seems to be a lot of detail still pending.
Yeah.
What subsets of patients benefited. It is a very broad inclusion criteria. So definitely looking forward to a paper coming out on
But,
this.
I guess the question is it worth doing, even if the only thing that really bears out to be benefited is a skeletal related event? If I think about a family member, I think I'd sign them up for 8 grade times 1 or something like that if it keeps them from having a bone fracture or from,
So I guess another
experiencing
question
pain, crisis.
in that perspective was, I didn't really see the breakdown of the skeletal related events. What percent of those were just local treatment for symptoms?
Right, that's right. I don't know that. I mean, I do know that hospitalizations were decreased, from like 5 to none or something.
Yeah, I guess you could argue if you're treating a bunch of people so that a few of them don't get painful lesions and then have to get treatment is one thing. But, if you're really reducing the risk of fracture and more severe skeletal events, that would be another.
Yeah, that's true.
Yeah, I think like practical implementation, you're hitting on this a little bit, but, identifying asymptomatic bone mets when you're not necessarily seeing all of these patients and getting them referred to you, practically becomes a question of how do you implement it, and do you have clinic space to follow every palliative patient that you treat, forever, and is that a good use of their time, from a patient's perspective as well. These are interesting things to think about, but definitely exciting, and I think as we get more data, potentially has a large potential to impact practice.
I hope we have time for if anyone wants to chime in. If anything, we wanted to have a discussion, but I guess we're long-winded.
There's just every year, there's just always more and more updates to chat about. So thank you guys for a fantastic review. Folks that are online, feel free to hop in and verbally ask a question. Otherwise, I am monitoring the chat. I think our speakers have done a nice job when their colleague has been speaking to kind of address some of the things, in the chat. For this this most recent one that you were presenting, Laura, one of the challenges that I see, implementing it is I think of our gentleman with, that presented with bone disease, and then you've got some kind of treatment and you look at that scan and, is it an active met or is it a treated met? And how best, what tools do you utilize to go forward? I mean, I think I currently struggle with that. I'm like, well, if it hurts, I'm going to treat it, even though it may, sometimes imaging wise, it can be a little challenging to tell. Prostate, I think you've got, PSMA, but some of our other disease sites, I think, become more challenging to just make those decisions.
Yeah, definitely. I guess I would say I would only treat it if you were just really certain, because it's such a soft call anyway. I think a lot of these patients are pretty newly diagnosed, so you were pretty confident it was, active disease.
Okay.
But I get what you're saying. Yeah, a lot of times if you're not dealing with, a PET scan and you're talking about bone lesion, it can be really hard to tell if it's active or not. And they've been on treatment for a while.
And then, just maybe for kind of opening up a little discussion, because I think many of us were trained in an era where, all mastectomy patients got bolus. In my own practice, I too have kind of slowly let the bolus go. And now I'm at a point where, with the exception of, inflammatory and pre-op skin treatment, are starting to not do bolus. I was just curious for, we have 3 providers in 3 slightly different settings. Do you guys have kind of your go-tos that like, yep, these patients still get bolus?
Laura is our resident expert. Okay, I'll go ahead.
I mean, if you had skin involvement, obviously inflammatory. So any of those, what I would consider high risk features, or maybe sometimes people, or positive margins after mastectomy, or maybe like a really advanced tumor that was really large. I will use bolus on those patients. And I usually do. So I kind of think of it, if I'm intending to treat the skin, then I'm going to go for it and treat the skin. So I usually do bolus daily. That is a good question from that trial. Should you do daily or every other day? But I usually do daily in those patients. And then, maybe a rare, like if you could think of an extremely thin person that their chest wall is a couple centimeters thick, and I need something just to get the dose to deposit on the chest wall, then that might be a scenario where you just need bolus for dosimetric purposes.
Mm-hmm.
I don't have a lot of those patients though.
Yeah, I pretty much always do whatever it takes to get the dose to be within, about 4 millimeters of the surface. Unless, of course, inflammatory, every day, 1 centimeter bolus. And then, yes, if there's a known ulceration at T4, I agree with Caleb. I would do every day because it's in my target. I mean, that's definitely part of the PTD is the surface. But you come across a lot of, bolus use outside of, just to get it to there. If you have a wide separation with, you need to use 15x, you're going to use bolus. But again, only to get it to within 4 millimeters of the surface.
No, that's very helpful. There was one question from Dr. Roberts that I don't know that maybe that might be a good one to end on, referencing Sam, the study that you presented, the MMAI, and kind of just current thoughts on comparisons of that. Does it need more data versus like Polaris or Decipher? I think you touched on it a little bit, but I'd love to hear some additional discussion there.
Yeah, so I mean, my understanding of Polaris and Decipher is that they're genomic based, looking at the genomics of the tissue along with some clinical data. I think particularly for Polaris, and I think for Decipher as well. And you have MMAI, which is looking at pictures of the biopsy slides in with clinical data. And so, presumably there's valuable information to be gained from all of that data, and sort of teasing out which one is best. I mean, I definitely don't feel that I know the answer to that, and probably is going to be an area of ongoing exploration. I think that, the way that I think about it from a counseling perspective is using one of these tools that has, validated data to help you to counsel your patients. And, one of the things that was interesting in our conversation that we had with Dr. Tord was, just sort of this idea of, sometimes we're hesitant to set thresholds for, what we would recommend a treatment for versus not. And I do think it's important to include patients in that conversation, but he was sort of talking about this number needed to treat of 25 being a pretty widely held threshold in some of the research data that they had done from surveys across a lot of different patient types. And so, just kind of using these tools to understand what is the number needed to treat and how do you present that to a patient in a way that they can understand that and that it can be meaningful for them in terms of, do I add this therapy? Do I not? What's my absolute benefit? And I think all of these tools have the potential to do that on some level. But I think that more to come on that.
Yeah, and I was I guess not knowing the details of it sounded like the AI primarily based a lot of its prediction off of the images of the slides. So
he said a way to think of it would be that something like 80 to 85% of the score came from the image.
Yeah, so I guess that suggest that there's going to be variation between pathologists in interpreting those slides and giving a Gleason score. So is it just maybe providing a more accurate or more predictive estimate of risk, or reclassifying people based on something that's seen in those images that maybe a pathologist doesn't necessarily score or pick up on.
Yeah, no, I mean, that's a great point because, Gleason score, I think, is added in the clinical factors, but we all know that there's a degree of subjectivity to that and a lot of data about going from one institution to the next and you having a change in Gleason score, somewhere 20 to 40% of the time or something like that. And so, I think it's a good point.
Yeah, I think it might be more representative of the actual biology, even than like PSA, because PSA could just be, well, how long did that person take to present, So I think that's where it's kind of been more accurate in determining metastasis risk than kind of what we've traditionally had available.
Well, thank you guys so much. I feel like I just kind of started getting the hang of using Decipher in my practice. And so I'm not really ready for anyone to come up with anything new, but if they do, then I need them to compare it very quickly and then tell me which one I'm supposed to use. But thank you guys all so much. If you had any parting thoughts, feel free to share them, but we are kind of right at 2 to 3 minutes over here. So otherwise, unless someone jumps in quickly, we will close the webinar. Thank you again.
Thanks. Have a happy holiday, everybody.
Yeah.
Thank you all. Happy holidays.